our April meeting. The agenda is fairly packed today. This is the meeting at which we vote on the plans. So, and the plan designs, which is always a bit of a logistic challenge because there's so many votes. And in order to sort of expedite that, I've asked Susan to sort of run through all the plan designs, and then we'll do the votes all at the end. And Marcin will read the specific votes because he does a better job than I do with that. So with that, let's jump in. Marcin, your opening remarks.
Yes, Mr. Chair, thank you. And this meeting is being recorded for minute-taking purposes, as well as for posting of the recording of the proceedings on the agency's website. This meeting is also being live-streamed on the Access Health CT website. This meeting is also broadcasted on Connecticut Television Network. It is requested that participants introduce themselves every time they speak, and roll call votes will be taken for every action item. Mr. Chair, would you like me to do the roll call for the attendance?
Yes, please. And this is Charlie Klippel here.
Thank you, Chair. Thank you. Paul Philpott, Vice Chair.
Here.
Grant Ritter.
Here.
Deidre Gifford.
Here.
Steven Hernandez.
Here.
Thank you. Matthew Brockman.
Here.
Thank you. Thomas McNeil.
Here.
Dina Berlin.
Here.
Andrea Barton-Reeves, DSS Commissioner.
Here.
Thank you. Kathleen Holt, OHA.
Here.
Claudia Gualtieri, OPM.
Here.
Trisha Dave, Connecticut Insurance Department.
Here.
Thank you. Manish Utani, DPH Commissioner.
Here.
Thank you. And Caroline Zambetti on behalf of Nancy Navarrete, DMS Commissioner.
Here.
Thank you.
Thank you. It's everyone. We have a full house today. That's fantastic. That's terrific. If I could ask the executive team of Access Health to introduce themselves. James, starting with you.
Thank you. Good morning, all. James Michelle, Access Health Connecticut.
Good morning, Gina Walsh, Access Health Connecticut, Director of Operations.
Good morning, Holly Zwick, Director of Finance, Access Health CT.
Good morning, Susan Rich-Bai, Director of Legal and Governmental Affairs, Access Health CT.
Good morning, Elaine Mann, Director of Marketing, Access Health Connecticut.
Good morning, John Carbone, Director of Small Group, Product Development and Broker Support.
Good morning, everyone. Glenn Jurgen, Director of Human Resources, Access Health Connecticut.
Good morning, everyone. Marquise Davis, Director of IT, Access Health Connecticut.
Thank you. Thanks. I think that's it. Thank you, everyone. Marcin, I understand there are no public comments today. Is that correct?
That is correct, Mr. Chair. We did not receive any public comments today.
So we will move on to approve the minutes of the last meeting. First, I'll ask if there are any comments or corrections to those minutes. If not, I would ask for a motion to approve the minutes from the last meeting.
So moved. This is
Thank you.
Deidre Gifford.
Thank you very much.
Paul,
second?
second.
Thank you, Paul. Without further discussion, if any, this is Charlie Klippel. I abstained because I was not at the last meeting, so I apologize. But
okay. So, Mr. Chair, so there just a formality. Is there any discussion on the motion before us?
Oh yeah, sorry. Any further discussion? If not, then now I will abstain.
Okay, Charles Klippel abstain. Paul Philpott?
Yes.
Grant Ritter?
Yes.
Deidre Gifford?
Yes.
Steven Hernandez?
Yes.
Matthew Brockman?
Yes.
Thomas McNeil?
Yes.
Dina Berlin?
Yes.
Andrea Barton-Reeves?
Yes.
Kathleen Holt?
Yes.
And Claudia Gualtieri?
Yes.
Thank you. Motion passes. We'll
Thank
turn
you
it over
all.
to Susan, I believe.
Yes, Susan, please.
Thank you. Good morning, everybody. It's nice to be here with everybody, as Charlie said. So this morning we have a vote to add a member to the Health Equity and Outreach Advisory Committee. And pursuant to the bylaws, the board has to vote when members are added or removed from any of the standing or advisory committees. So we are bringing this before you today for a vote. And today you should have received materials. We are asking that Aisha Clark be added to the Health Equity and Outreach Advisory and Consumer Experience, Advisory Committee. And Aisha brings a wealth of experience and knowledge in the consumer space, so she will be vitally important to add to this committee. She currently serves as the Executive Director of Health Equity Solutions, and she started there in 2020 as the Deputy Director and then moved her way up and has been the Executive Director since 2023. And Health Equity Solutions focuses on advancing health equity efforts in Connecticut through policy and advocacy initiatives. So Aisha is perfect in her work and her experience for this role. She also serves as an adjunct professor at UConn. So I hope that the board will be interested in adding her to this committee. We really would value her input. Thank you.
Thank you. Susan, any comments or questions about this appointment?
This is Claudio. Just want to say, oh, sorry, Commissioner Barnes has her hand up, so I'll wait and let her go first.
Oh, thank you, Claudio. You don't have to be speaking first. I so enthusiastically support this appointment. I have known Aisha for a number of years. She really is exceptional in so many ways as a leader, as an advocate. She's been extremely active in the Hartford community, and I think she really understands the communities that we are trying to serve through the exchange. So I'm in full support of her appointment.
Fantastic. Claudio?
Thank you. It's Claudio. Now, I do wish I went first because Commissioner Barnes said it so much more eloquently than I would, but I just want to say very fantastic addition to our team. And I think when we look at the mission of Access Health, looking at health equity and reaching people where they are, but also a lens towards affordability, Aisha's been a fantastic partner with us on the executive branch on a number of health affordability legislative proposals and policies, and also incredible work on medical debt erasure that we've been able to do together. And I know she brings that lens of helping us navigate the next turbulent time with HR1 continue enrollment. So happy to have this appointment and enthusiastically support. Thank you, Chair.
You. Stephen?
Thank you, Mr. Chair. I also wanted to lend my voice to enthusiastic support for Aisha's candidacy and service with us. Having worked with her for many years, I find her advocacy to be nuanced, researched, and thoughtful. So I enthusiastically advocate for her as well.
This is terrific. Thank you very much, all of you. Any other comments? If not, then I would ask to proceed to a what do we need? A nomination to a motion to appoint Aisha Clark to this committee.
So moved. Andrea
you.
Barton.
Andrea, thank you. Second. I'm going to take Claudio's endorsement as a second. And
I will second. Thank you.
There we go. Thank you very much. Any further debate? If not, then Charles Klippel, yes.
Paul Philpott?
Yes.
Ron Grader?
Yes.
DJ Gifford?
Yes.
Steve Hernandez?
Yes.
Matthew Brockman?
Yes.
Thomas McNeil?
Yes.
Dina Berlin?
Yes.
Andrea Barton-Reeves?
Yes.
Kathleen Holt?
Yes.
And Claudio Gualtieri?
Yes.
Thank you. Motion passes.
Thank you very much, and welcome to Aisha to this committee. It's going to be great to have her with us. James, the floor is yours.
Thank you. Good morning, all. Like many of you on the board, I've known Aisha for several years, and we look forward to her thoughtful experience contribution to our board. We are excited to have her joining the Outreach Committee And Tammy, who heads up that part of our organization, has worked with her in her organizations over the years. So we are very excited to have her on board. Good morning, all. I'm James Michelle, the Chief Executive Officer of Access Health Connecticut, and thank you for being with us this morning. Before we begin, I wanted to share a few updates. First and foremost, we have a new Director of Marketing, Elaine Mann. You saw her a few minutes ago. Elaine comes to us with extensive experience in marketing and communications. She joined us on March 24th. We're excited to have her as part of our leadership team. We are conducting an email survey of the customers who have not renewed their health insurance plan through Access Health Connecticut for 2026. The survey began on April 13th and will run through May 8th. The goal of the survey is to understand why customers did not renew their coverage for plan year 2026. We are reaching out to 20,000 customers with the goal of receiving at least 800 responses. We understand that is the statistical number that we need to have a viable survey. The survey will be offered in English or Spanish based on the customer's preference. The process should take no longer than 10 minutes. We will share the results at the board meeting later this spring. Moving on to the next item. As you know, part of the One Big Beautiful Bill Act last year was the elimination of the repayment cap on excess financial help customers may have received throughout the year. Again, these are the advanced premium tax credits. Customers come to Access Health, they project how much money they think they're going to earn. And if they project a number that's lower than they actually earned, they have to pay back some of that money when they reconcile with the IRS. There were caps on how much they got to pay back to the IRS. Prior to 2026, there were limits on how much certain customers have to pay back if they receive excess financial help. Those limits have now been eliminated. So it is critical that we continue to that we update our customers, that our customers update their accounts. If there's an income or household size change during the year, where they could owe the IRS a lot more money than they usually owe. We are committed to sharing this information with our customers to ensure they are aware of this change and informing them of steps they can take to avoid unexpected costs. We are sharing information on our social media platforms as well as sending emails to customers. We have updated our website with a blog article about these changes. We have also sent out a press release. We'll continue to communicate this change to our customers over the coming months to help them avoid additional financial burden. Our meeting today will begin with an update from Holly Zwick, Director of Finance. Holly will share our third quarter operating budget report for fiscal year 2026, as well as the proposed operating budget for fiscal year 2027. The Finance Committee has reviewed and approved both of these items at its meeting last Thursday. Holly will also give an investment report to the board. Following that, Susan Richby, Director of Legal and Government Affairs, Kelly Cody, Plan Management Manager, and Ren Zong of Wakely Consulting, our actual consulting firm, will share the 2027 plan recommendations from the Health Plan Benefit and Qualification Advisory Committee. The focus for the committee this year is affordability and how we can continue to offer our customers health coverage that makes sense for their budget. These recommendations are typically shared with the board at the board meeting earlier in the year, but we did not receive federal guidance from the Centers for Medicare and Medicaid Services until late February. We normally get this guidance in December. In time permitting, Susan will give a legal and policy update on the Affordable Care Act. Once again, thank you very much for being here today, and I'll pause for any questions.
Thank you, James. You have to say a word about the Innovation Award.
We were recognized for our approach to help address health disparities in creating the Broker Academy. We did a study several years ago that indicates that told us that if those who were on the highest uninsured areas in communities of color, there was a severe lack of access to information to answer questions, to provide guidance. And when we looked at our own system, the state system, most of those communities of color had very limited to no brokers of in their communities that look like them, spoke with them, and also understand their culture. So in 2022, we created the Broker Academy to recruit from those communities and support them while they go through the process to become licensed brokers. And the effort is to help us address health disparities across the board and also lower the uninsured, which is core to our mission at Access Health. So the organization recognized our effort and a new approach to try to help these ongoing challenges across the healthcare and system in the country. So I'm very proud and very happy for our organization that we recognize for the work that we're doing to help address health disparities and move us a little closer to achieving our core mission. Thank you.
Terrific. It was terrific recognition for a piece of work you've been doing for 2 or 3 years now. It's really great. Any further questions for James? If not, I will ask Holly to provide the financial information.
Certainly, thank you. Holly Swick, Director of Finance, Access Health CT. Good morning, Chairman Klippel and members of the board. I hope you're all doing well. It's nice to see everyone, and welcome, Aisha. As James stated, today I will be discussing the fiscal year 2026 quarter 3 budget, as well as the proposed budget for fiscal year 27. This information was shared with the Finance Committee last Thursday, and they voted unanimously to approve these budgets. Next slide, please. This slide shows a summary of our fiscal year 26 third quarter budget versus the actuals. And so this was as of March 31st of 2026. Access Health is currently $258,000 under budget, primarily due to timing. And I'll go into more detail on the next slide. Please, thank you. Here we provide a more detailed comparison of the fiscal year 26 budget versus actuals as of March 31st. On the revenue side, we are over budget, driven by stable interest rates and higher than projected assessment revenue. On the expense side, savings have been realized in salaries due to the timing of staff hiring. The remaining variance in savings are due mainly to the timing of projects and invoices. Next slide, please. We don't foresee any changes in the fiscal year 26 operating budget or our shared costs with DSS. Next slide. This slide shows the full year budget adjusted after the 3 quarters in more detail. On the revenue side, we are over budget by approximately $467,000 after the 3rd quarter, with a plan to put the dollars into the reserves. For grants, we are projecting approximately $50,000 for fiscal year 26. Interest income has continued to increase as rates have remained steady, and calendar year 26 assessments are higher than projected. On the expense side, we are currently on track. We see savings in salaries as well as temporary staffing as we converted 1 temp to full-time employee. In addition, some of the contractual work has been moved to IT enhancements, including $300,000 for TPA, which is Connecticut Temporary Premium Assistance. We see equipment and maintenance savings due to the negotiation of maintenance work and dollars moved into the IT enhancements line item to fund 10 clicks. Next slide, please. We don't foresee any changes in the fiscal year 26 operating budget or our shared cost budget with DSS as of the close of quarter 3. I'll pause now for any questions.
Are there any questions? Very straightforward. So, yeah, please.
Yeah, Mr. Chair, Claudio, just if I can say, the Finance Committee did review all this and work through it. Very happy to see the investment from Access Health to try to operationalize our state backfill subsidies. We're very fortunate to be one of the few states, and Governor committed with the legislator's support to easing that transition as Congress failed to act on the subsidies, and hopeful that now we have the full IT system upgrade. People can come back into the system and see the net savings with the state assistance applied, and I think on early indication over 10,000 people were benefiting already, but I suspect that will go up now that people can see the total cost. So very proud of our collective work, OPM obviously led by the governor's team, and DSS and the Access Health team. So congratulations and thank you for that investment.
Great comment. Appreciate that. Any other thoughts? If not, and Marson, I'll try to read this one myself. I would ask for a motion to approve the fiscal year 2026 third quarter budget report operating as presented by Ms. Zwick. Could I have a nomination or could I have a motion?
So moved, Deidre Gifford.
Thank you, Dr. Gifford. Second?
I'll second
I'll
Kathy
second it.
Holt.
Okay, I'll let Marson sort that out.
I think Ms. Holt.
Okay, thank you. Any further discussion? If not, then Charles Klippel, yes.
Thank you. Paul Philippot.
Yes.
Krongreiter.
Yes.
Deidre Gifford.
Yes.
Steve Hernandez.
Yeah.
Thank you. Matthew Brockman.
Yes.
Thomas McNeil.
Yes.
Dina Berlin.
Yes.
Andrea Borton-Reeves.
Yes.
Kathleen Holt.
Yes.
And Claudia Galtieri.
Yes.
Thank you. Motion passes.
Thank you. Holly, the floor is still yours.
Great. Thank you, Chairman Klippel. Holly Zwick, Director of Finance. Our proposed fiscal year 27 operating budget emphasizes technology investments, outreach, and health disparities, all aimed at advancing our mission. Next slide, please. Our fiscal year 27 proposed budget is projected to increase by approximately $5,017,000. Excuse me. Most of this will be invested into 10Clicks, as we will be in the midst of implementation at this time. Our shared budget with DSS will decrease by $450,000 as DSS completed the Wakely actuarial study for Covered Connecticut. Next slide, please. Year 27 proposed budget. Grant income has been held flat at $250,000 as we will continue to engage both internal and external stakeholders to identify and develop fundable projects. We anticipate interest income to decline slightly, reflecting a stabilizing and modestly declining rate environment. And other income is also projected to decrease due to lower rebates and the continued departure of vendors who previously utilized credit card payments. Marketplace assessments are estimated to rise by close to $5.1 million. Revenue is increasing because 2025 had higher individual market enrollment. Please note that assessment revenue is calculated from premium revenues reported for 2 years prior, and there are some legislative proposals with the potential to impact enrollment numbers in 2027 or future years, which could lead to decreases in the 2029 assessments. The additional 10% in revenue will be going to new capital development. The 10Clicks project will cross at least 2 fiscal years and will require parallel systems running to ensure data coming out of both are identical. Moving on to the expense side, we are projecting an increase of approximately $515,000 in salaries and fringe. This is driven by a 3% merit increase and a 10% rise in health insurance costs, reflecting the increase from last year. We are proposing temporary staffing to remain just about flat, with a small increase of $5,000. Now, moving on to the contractual line item. This encompasses the call center, operations, marketing and outreach, and vendor contracted resources. We are proposing an increase of approximately $338,000 to this line item, primarily due to the need to bring awareness to upcoming OE changes in marketing and outreach, as well as higher demand and increased cost in media buy due to it being an election year. Our next line item, IT enhancements, is increasing to fund the implementation of our new system, the 10Clicks project, and travel will remain stable at $125,000. We will see a small decrease of roughly $2,700 in the other administrative line item as we continue in our efficiency efforts. Next slide, please. Our fiscal year 27 proposed shared cost budget with DSS, as stated before, is decreasing by $450,000. As mentioned previously, this is due to the completion of the Wakely actuarial study for Covered Connecticut. At this time, are there any questions on the proposed fiscal year 27 budget?
I think Dr. Gifford has a question for you.
Certainly.
Thank you. On the very large increase in the IT budget, that it's a noticeable number. I don't know if that's a 60% increase year over year in the IT budget, something along those lines. And I just wonder if the finance committee or anybody, any other subcommittee of the board, Charlie, has looked in detail at the total cost of 10 clicks and whether we're on target, with our proposed plan for that project. I know we've been working on it for quite a while. I may have missed it. I'm a little bit surprised by this very large jump in the cost. I'm not sure that we've discussed it as a board. So I just wonder if that merits a little bit more explanation for us and for the constituents of Access Health, or has that already happened?
Mr. Chair, if you don't mind, can I respond to Dr. Gifford very quickly? Thank you. To put this in context, the current system we are using was built in 2012, 2013. It cost over $100 million in total. And most of that money came from the federal government. And all of it came from the federal government. We had no idea what we were doing back then, because we didn't have any data about our customers. The feds were developing the policies as we were building the system. So there are a lot of inefficiencies built into the system because of that. Now we've had over 12 years of data from our customers, our employees, and our partners, brokers, and CSEs that we have. So we started about 2 years ago to study our current system. Where is it lacking? Where are the gaps? And we've done that study. We put it out to bid. And based on that, we've come back with numbers that's less than 10% of what we paid for the original cost. We're still negotiating with the vendor. The cost at this point is less than 10%. It was a comparative bid. We have 4 responses. We came down to our top 2 bidders. We selected one, and it was awarded last week. And we are currently negotiating a contract. So I'm not limited to disclose what the value of the contract is. But again, I would say it is less than 10% what we pay for the original system. Now, guys, less than 10%. We think that the pricing is a fair and accurate one, and we have been communicating with the strategy committee. And Dr. Gifford, we are planning, just for this, for the entire board, we are planning on having a board workshop in early June to go over all the details with respect to 10 clicks and other projects that are going on. But we have been at this for a while now. We believe our cost, it's a competitive bid. And most of this cost, we have a small window to get this done. But we think in about 3 to 4 years, our revenue is going to start dropping, simply because the enhanced subsidies that went away. As the premium dollars come down, our assessment revenues will come down. And so we have this done now, and this will lead to lower operating costs for us with respect to call center and other costs for the organization, because the system we are building will be much more efficient than what we have in place now.
So
that's very high level. Yes.
So James, sorry to interrupt, but just so I'm clear, I had previously understood that 10 clicks was an enhancement to the existing system, and it sounds like now what you're talking about is a replacement. Am I missing something here about what 10 clicks actually is?
Yeah, 10 clicks. It will be we are developing an entire new platform to replace the platform we have in place now. The platform we have in place right now, it'll take you to go through the entire process. If you are a Medicaid applicant, over 200 clicks to get through the entire application. Our goal is to get it down close to 10 clicks. Hence the name 10 clicks. So again,
understood. I understand. I'm just trying to understand what we're being asked to vote on here, which is a very large increase in the IT budget. And I'm not sure, I speak for myself, I'm not sure I totally understand what's behind that large increase.
it's an investment. It's a capital investment in developing a new platform for our customers, for all kinds of customers to apply to get access to health insurance, in addition to operating the day-to-day function, customers calling in. And this is not just for us, this also impacts Medicaid. All Medicaid applicants come through the process as well. It's not just, and when you apply to Access Health, we don't know if you Medicaid or QHP until you go through the process. And
James.
typically yes.
Oh, I'm sorry, I don't mean to cut you off. And Stephen also has a comment. I think Dr. Gibbs is asking a slightly different question, which is, excuse me, is this, we knew we were undertaking this investment. It seems like a good time to do it because we are fortunate to be in a sort of positive revenue moment at the time, and it's the best time to do this kind of systems enhancement. I think part of what Dr. Gibbs is asking, and I'm paraphrasing here a little bit, is it on track? Is it kind of within the scope that you were anticipating? And do you see it getting done on time and on budget, and then kind of what the savings are going to be at the other end of that? So is it sort of within the scope that you've been contemplating, and in terms of where we're going here?
Thank you, Charlie.
Yes, we are. The target is to go live June of 2027 in preparation for the open enrollment of 2028. Right, we are on track for that to happen, and we have a detailed project plan that we are in the process of executing. The entire organization is on track to make that happen. So I hope that answers the question. That yes, we are on track. The scope of work was developed internally as well, with some input from some of our customers, our brokers, and our employees. We have a detailed project plan, which we did not have when we created the current system, because we had no information at all about anything. After 12 years of data in our system, a survey we conducted of our customers, employees, and partners, we had more detailed information for us to develop a brand new system platform that's much more efficient, much more efficient. So we do know that we will save some money. We are doing the assessment now, but we know it'll be well over $1 million, well over $1 million year over year at a minimum. One thing we are currently doing in preparation for this, as any employees leave the organization, we do an assessment of that role. Will we need that role in a new environment? At the end says no, we don't backfill it. But if we still need the work done, then we would hire temporary staff to do the work while we do that, so that when we go live with the new system, we would not have to terminate anybody. No one will lose their job. So we are more than happy to walk the board through the detailed plan, and not just from the technology part, but also the people part of it, in terms of change management, the impact this is going to have to our customers, our employees, and also our bottom line. So, and we are planning, Charlie, we are working on putting together a board workshop in mid to late June to walk the entire board through the entire project where we are.
So I think Stephen, Duder, bear with me, Stephen and Claudio. Stephen first.
Thank you. And thank you for that explanation, James. I think it's important to really underscore that there are a couple of things that are happening here. One is that as the IT advances, the real question whenever it is that you're updating a system is whether you put shellac on rotten wood or whether you just rebuild from new and available technology. And I think that's part of what we're seeing here. Yeah. And then the other element of this is that this is more than just IT from how you're describing this, James. This is systems, interface, customer service, direct delivery. It really does impact the entire operations of how it is that you're delivering and interfacing with with the people of the state. So I'm looking forward to that workshop and that training that you're describing, because I think it's important that I and we be able to understand exactly all of the ways in which this innovation is touching the agency and our customers.
Thank you. Claudio?
Thank you, Mr. Chair. I think as part of that workshop, I would respectfully ask that we have a deep dive to understand how the new 10 clicks and this IT investment on the Access Health side is going to work in coordination and be synergistic with the investments we're making on Medicaid eligibility determinations as a result of the community engagement requirement. So we have a lot of work going in with an advanced planning document that our DSS colleagues have done, yeoman's work to be one of the leading states in trying to operationalize those investments. And I just want to make sure we're not duplicative. I understand the 10 Clicks initiative has been many years in the making, and so we need now to align it to the realities of a changing landscape and Medicaid and bring those together. I would like us to make sure we're maximizing the opportunity to build one off of the other and avoid duplication. So probably not for this discussion, but I'm going to ask that that be a very focused part of the board workshop and a deep dive on that.
Claudia, we will. That's part of our strategy when we talk with the board. But you should note that the DSS team, they've been part of every step that we've been doing since we started, going back 2 years. They were part of the survey, get their input. They've been part of the review process for the RFP. So they've had input opportunities to have input to be part of the process from the very start. But
yes, I'm
to answer
just
your
noting.
question, we will give a full update on the integration part between us and the DSS system, making sure we are the synergies there, to make sure we're not duplicating what they're doing and they're not duplicating what we're doing.
Yes, and I just note that because you just said the point that's very critical. 2 years ago, this project started, and you guys were having engagements under a different reality. So less than a year ago, we had HR1, which is drastically changing both Access Health and certainly the Medicaid program. So now we just need to reflect that new major inflection point to see if our assumptions and how we were going about doing it still applies, and how best to make sure we're taking advantage of the new situation.
Will do.
So, Deirdre, a last word?
I've been trying really hard to lower my hand, but I haven't been able to. So I think I said my piece, but my little hand won't go down.
Okay. So, James, this is, I think, the biggest capital investment we've taken on during my tenure as the chairman of the board, and it's a really important one. And I do think the timing is fortuitous. So, and by my sort of historic standards, this is the cheapest systems update I've ever seen, but it's still a major budget item. So I think we're trusting you on this, but we're also very interested in the retreat. We're very interested in sort of seeing the details coming up in June. So we will all be watching that very carefully, I think.
Well, Charlie, you and the board are not alone, because obviously this is a major undertaking for the entire organization, because we are looking at changing everything that we do. So the amount of risk in doing this is very high. This is why we have been slow walking this for 2 years, to make sure we cross every T, dot every I, which still doesn't guarantee it will go perfect. But everything that we are doing, from the surveying our customers, surveying our partners, working with all of our partners, DSS, BITS, CMS. CMS has used with everything that we're doing. They sign off on everything that we're doing. They're aware of what we're doing. IT security. So it's taken a long time to get to the point where we had an RFP finalized with the statement of work to put out to bid. In 2 years to get to all that, it started with our customers, our partners, and our brokers. So everyone's had input in developing the strategy for this. Now, having said all of that, we have an internal team that's doing this. We're doing this ourselves. We didn't hire. The reason that the price is lower, Charlie, because all the work we've done over the last 2 years, most other organizations would hire a consulting company, a Deloitte, KPMG, a McKinsey type, to come in, do the assessment, then tell them what they need to do. We've done that ourselves. Our customers.
No, fair enough. I'm impressed by the work. Yeah, I think it's I think it's both necessary and you've been doing a very diligent job. So I guess what I'm saying is we are with you, and but we would love to. I think we're all looking forward to seeing the detail coming up this summer.
Yes.
That took us a little bit an important detour, but a useful one. Holly, I'm going to
Charlie,
go
it's
back
Paul.
to you. Oh, I'm sorry, Paul. I didn't see your hand. I'm sorry. Please go ahead.
Yeah, just a technical question. I'm presuming that the capital investment, the finances on this were presented to the finance committee, presented and approved. Is that right?
Yes,
Yes.
it was part of the approve last week.
Okay, thank you.
Yeah, thank you. Useful question. Thank you. Holly?
Thank you. Holly Zwick, Director of Finance. Thank you for all the commentary. We're all very excited in the office. Buzz is very high about the 10 Clicks initiatives. So it's really nice to hear your thoughts and comments on this. Thank you. Moving on to the fiscal year 26 surplus, we're projecting a minimum of $467,000. As mentioned earlier, but we anticipate the surplus to be closer to $1 million with our pursuit of greater operational effectiveness. We are projected to end fiscal year with approximately $20.7 million in reserves, which equates to 5.3 months of operating funding. Even though our reserves are increasing due to expenses increasing at a higher rate, our months of operating revenue has decreased slightly. Next slide, please.
Okay, so you're going to let me ask whether there are any further questions, discussions on this proposed 2027 operating budget.
Mr.
Please.
Chair, we don't have a motion before us, but I will just say that I feel slightly uncomfortable as a board member voting on this $9 million figure prior to the presentation that Claudio asked for. I may be alone in that, but I feel, to James's point, this is among the most significant initiatives our organization has ever undertaken. And if this vote represents the board's sign off on that initiative, it feels like we're doing this in reverse order. We should have the presentation on the substance before we vote on the budget. That being said, I don't think that we obviously don't want to muck up the general operations of the organization by delaying any vote, but I feel like we've put the cart before the horse a tiny bit here with the budget before the detailed board sign off on the actual initiative.
A fair point, Susan. Maybe this is a technical question for you. What impact if we delay the vote?
I guess if the board retreat, from my understanding, actually board training, sorry, just to put that in there, is scheduled for early June, I believe the second week of June. So I believe as long as the FY27 operating budget is adopted before the end of June, that would still work. I know not optimal, from a finance perspective, but I believe that would work.
Holly, what impact to you and James to you if we just said we'll take this vote after your board training?
The only impact to us is the delay in signing a contract with the vendor. And then again, there's the goal is to start working on the project, the detailed project in May. So this may delay go live by a month or two. Again, this is we have a very detailed project plan. Everything is accounted for, and again, with some room for unexpected events going on. So this may delay the project a little bit. And then we don't know what the impact is to the vendor that we are currently negotiating with, but we anticipate we want to sign the contract by early to mid-May, so they can start working on the project. If we have to wait until June, it may delay the project, and we do want to go live before for the 2028 open enrollment is the goal. But there would be a schedule at the minimum a scheduling impact. But if the board is able to vote today, we could always adjust that we are doing. After, if the board wants to make adjustments, we could always adjust it afterward as well. So if after the go ahead.
This is Claudio, Mr. Chair. If I could, I think that Director Gifford also brings up a good point here. I think the board has some sufficient reservations. There's lots of moving parts here. I think it's worth our while to take a short delay to make sure that we're getting the full picture. We want to get this right. We want to make sure it's aligned with the investments happening on the DSS side of the house. If it's a motion that that Dr. Gifford has put on the table, I would be happy to second it, or we can just choose to pull this out, schedule the board meeting, and then take it up at another time. So I'll defer to you on the process, but if the motion is there, I'm prepared to second it.
Sure what motion is there, but maybe it's to approve the budgets X this line item, or what is the motion you're proposing?
I wasn't, but let me think out loud a little bit. Perhaps we could approve a budget with a flat IT line item. I mean, we know we're going to need an IT budget. It's really the delta that I think merits further board discussion between fiscal 25 and fiscal 26. So, and I take James's point about, wanting to keep this moving, and I certainly don't want to unduly delay the go live. So maybe we could, at a future meeting, approve the budget with the flat IT or normal annual increase, 3 or 5% year over year increase, and then do the deep dive on this very large bump. And vote on that separately. I don't know, Susan or James, if that would.
I would recommend we table this vote, the entire vote, until after the June workshop. We will still have time to update our system for the 2027 FY year.
If that's your recommendation, I would say that's probably the most sanitary way to do this. Susan, what that means though is that we've got like 20 days between the presentation and the end of the fiscal year. So we're gonna have to figure out how to get a meeting in there with a vote so that we get the budget approved in time for the end of the year, end of the fiscal year.
Correct, because the board training is a training just for the board, so the board can't vote on the budget at that time.
We'll have to anticipate what we're doing here and make sure that right after that training, we have a vote.
We schedule a board meeting, yes, for the vote. Yes, that would work.
Unless Stephen has a better idea, which I'm waiting for here, so I'll call on him.
I'm almost absolutely certain that I don't, but I do, and I am wondering on the detail of when the training is and whether there will be virtual options depending on what particular date.
Yes, we're looking at June 13th. Martin was going to send out a survey to the board, and it would be both. Well, we would encourage folks to be there in person, but we would do both remote, virtual, as well as in person.
Good. Okay. All right. So, James, I'm going to take you up on your proposal to sort of table this one. And I would suggest that, just to put my spin on it, this is not intended to be a a no confidence vote in the budget. It's simply a question of it being the largest expenditure that the organization has undertaken in the last decade or so, and just a chance to look at it. So with just that understanding, if you're okay, let's table this vote and come back to it after your board training.
Absolutely. And what we'll do in the meantime, we'll send out information to the board, detailed information to the board about the project, where things are, and we'll create a summary, executive summary. Then we get into the details at the board workshop. But you will have an executive summary with all the details behind it, everything that we've done up to now, and what the recommendation is, and what the way forward looks like, and executive summary, 2 or 3 pages executive summary with all the details attached to it, so that when we meet in the first 2 weeks of June, hopefully that you'll get more. We can spend most of our time answering your questions after a recap of the entire project. Hopefully that works. Okay.
And I think nailing down the date, because I see a couple of sort of dates flying by here, nailing down the date would be very helpful. We'll all make a point of being there in person or in spirit, and we will get a chance to hear this in detail. But all of that's very helpful. And look, I'm very enthusiastic about this project. I think it's very important for the future of the exchange. It's just helpful to walk us through it. So thank you.
Mr. Chair, I just would like to mention that the board training will be scheduled for June 9th, which is a Wednesday, beginning at 8:30 a.m. More details will be forthcoming.
Okay. All right.
Thank you.
All right. So if you would all try to accommodate that date, thank you very much. Perfect.
And I believe.
All right. Well, we took you on a detour there, but I think
I have
Holly, it's back.
June 9th is a Tuesday, Marcin. Is it the 10th? Or is it the 9th, but Tuesday? I just want to make sure, because this does sound like it's an important one. We're going to need maximum participation to take a vote afterwards if we schedule a special meeting that day.
I'm sorry, it's June 10th. My apologies.
June 10th.
June 10th.
Okay, thank you.
Thank you.
Wednesday, June 10th, 8:30 in the morning, location to be announced. Okay. All right. Important discussion. Holly, back to you. I think this time without a vote, but please.
Great, thank you. This brings us to the investment report. Holly Zwick, Director of Finance. To briefly recap, the objective for the Access Health Exchange funds is to obtain the maximum rate of return while preserving the principal and providing immediate liquidity. Access Health invests in the state of Connecticut Treasurer's Short-Term Investment Fund, also known as STIF. This account is available for use by the state's fund and agencies, and state statutes authorize these pooled investment funds to be invested in U.S. government and agency obligations. These investment pools are under the control of the state treasurer. Next slide, please. The year-to-date earnings on the STIF account are $920,801. Access Health CT's investment portfolio is in compliance with our investment policy, and we can meet our expenditure requirements for the next 9 months. That concludes my portion of the meeting, and I thank everyone very much.
Thank you very much. Any questions about this piece of the presentation?
Excuse me, I think we did have a vote, right, Marcin, on the budget report, the FY26 budget report?
Yes, we did have a vote. Yes, we did have a vote on. Did we? I'm sorry.
Yeah, they voted already, Susan.
Oh, my
Yes,
apologies, sorry.
Yeah, vote has taken place already.
Okay, perfect. So Susan, back to the sort of bread and butter of this meeting. The new plans.
Yes, and my apologies again on that last comment. So we are here today also to approve the QHP certification requirements, namely the standard plan designs for plan year 2027. This is a requirement under the ACA that each year the organization approve these requirements, and Access Health's policies have recommendations for this work coming through our Health Plan Benefits and Qualifications Advisory Committee. And Kelly Cody, who will be presenting, will tell you more about that committee. But I did want to just take a moment to say, as James mentioned, we are a little delayed this year because of the federal requirements coming out very late at the end of February. They're normally out in December. And so we had to make some adjustments working with the Health Plan Benefits and Qualifications Committee. And everybody was very flexible and very responsive. So I just want to express my appreciation. The committee actually met 5 times this year to go through everything they needed to go through. There were big changes to the AV calculator that required changes to all of our plan designs. So it was a lot of work, and I just want to thank all the committee members, the carriers, and Wakely for their hard work. And I will turn it over to Kelly Cody, Plan Management Manager. Thank you.
Thank you, Susan. Good morning to everyone. I'm Kelly Cody, Plan Management Manager here at Access Health Connecticut. And as Susan said, I, along with Ren Zong from Wakely Consulting, will be presenting the 2027 standardized plan design recommendations for both the QHP and the SADP products as recommended by the HBBQ. As many of you are aware, the members of the HBBQ represent a variety of backgrounds and interests. We have community healthcare advocates, a member from the Connecticut Hospital Association, and representation from each of the participating health issuers. We also have a member from the Department of Public Health and from the Connecticut Insurance Department, offering their expertise along with members of this board. This diverse group provides Access Health with meaningful input for the challenge of making thoughtful changes to our plan options. And their main objective is to provide benefit recommendations for the standardized plans that meet both federal and state requirements, while continuing to offer quality healthcare options to the Connecticut residents. So before I get into the heart of the discussion, I would like to take a few minutes to provide a quick overview of the certification workflow and timeline. Existing and potential issuers, you can go back to the previous slide. Existing and potential issuers are advised of the Access Health Connecticut certification requirements through the QHP and SADP solicitations each year. These documents provide a summarized outline of Access Health and federal requirements, as well as providing standardized plan designs, which we're about to discuss. But based on that guidance, any issuer that forwards a completed notice of intent to participate on the exchange will then receive the issuer application and supporting materials. And with all issuer applications are due back to Access Health on the same date that the rate and form filings are due to the Connecticut Insurance Department, which is June 1st of 2026. To provide the issuers enough time to respond to the application, Access Health usually targets the release of the solicitations shortly after receiving the Board of Directors approval of HBBQ plan design recommendations. So today we will be seeking board approval for the recommendations for the standardized QHP and SADP plans for plan year 2027. Just a note before we begin, we have final federal guidance for the maximum out-of-pocket and the actuarial value calculator for plan year 2025. But the IRS regulations relating to the high deductible health plans and the final notice of benefit and payment parameters has not yet been finalized. Additionally, state legislation sessions end in early May. So given the need to move forward, we will be presenting information based on what we know now. And if any of the proposed plans are later determined to be out of compliance with the federal or state guidance, we will come back to the board for further consideration. So for the compliance and regulatory variables, let me first start by saying, as Susan and James both mentioned, this year has been anything but normal. We typically start this process with CMS releasing guidance to us in early, sometime in December. And this year, as noted, it was released to us very late in February. So Access Health, Wakely, and all the issuers actually began the process of reviewing the standardized health plans in the 2027 actuarial value calculator shortly after receiving it from CMS. This is our starting point for developing the standard plan designs each year. And as Susan noted, we quickly identified that after putting our information through the new calculator, every single plan needed to be looked at and modified in some way. So this was quite a challenging year, timeline, everything changing, and then really trying to get everything done in a very condensed amount of time. So in spirit of Susan's commentary and thank you for everyone's flexibility within the issuers, Wakely, and also those who participated on the HVBQ committee. So what did we do? We tried to expedite the process as much as we could, and Access Health, Wakely, and the issuers behind the scenes went through multiple iterations of plan options, making sure that each issuer could be in compliance, and that is meeting the actuarial value ranges and also meeting federal mental health parity requirements. So that in itself was quite challenging. We did get there, and we were able to present that information right off to the committee so that we could just start conversations right off the bat with compliant plans and decide what needed to be changed thereafter. As Susan mentioned, we met many times during the month of March and April, having thoughtful conversations, providing suggestions for plan design enhancements, and we ultimately came up with the final recommendations that will be presented to you today. Ren's going to go over the regulatory variables related to CMS and IRS, but here I just wanted to reiterate a portion of what James had already said, that the enhanced subsidies did expire December 31st, 2025, as everybody I think is well aware, but premium tax credits still do apply for individuals and families with incomes between 100 and 400% of the FPL. And as I mentioned earlier, the state legislative sessions will end on May 6th. So we'll continue to watch that to make sure that there isn't anything impactful to our plan designs. You could go to the next slide. Thank you. So this is our proposed 2027 permitted plans. This is a plan mix for the individual and small group markets for the medical and dental plans that are offered through the exchange. For both the qualified health plans and the standalone dental plans, this slide outlines the number of plans by type that an issuer is required to submit, as well as the number of optional plans they may submit for certification. Currently, in the individual market, Access Health requires that each carrier submit 4 standardized plans, but allows each carrier to submit an additional 9 non-standard plans, totaling up to a total of 13 plans per issuer. For plan year 2027, the committee is recommending requiring 1 additional bronze plan, which we have labeled it Bronze Light. The intent of this plan is to help bridge the premium gap between the catastrophic plans and the current standardized bronze plans. Catastrophic plans are not eligible for premium tax credits, so the bronze Light plan gives consumers who might be eligible for premium tax credits the ability to offset the cost of the Bronze plan. Additionally, HHS has made all catastrophic and Bronze plans HSA eligible, so consumers can also take advantage of those tax saving opportunities. Ren will go over the plan design in more detail later during this presentation. For small group, there are no standardized plans. However, Access Health requires that small group plans do include certain plan perimeters, such as in and out of network coverage, pediatric dental, and vision EHB coverage. To offer the plans through the exchange, a carrier must offer the minimum amount of plans, which is 5, and they have the opportunity to offer up to an additional 15 plans, totaling 20 for the per carrier or per issuer. For plan year 2027, the committee recommends no changes to the small group plan offerings. As a side note, no issuer offers the maximum amount of plans in both the individual or small group markets. For the standalone dental plans, there is no difference in plan mix requirements across markets. Access Health requires that each issuer submit one standardized plan with the option to include or exclude out-of-network coverage, and they may also offer up to 3 additional plans, totaling a maximum of 4 per issuer. For the plan year 2027, the committee recommends no changes to the standalone dental plan offerings. So before I move to the next slide, are there any questions? Okay. So this is, we're going to start off with the standardized standalone dental plan, and Ren will move into the health plans. But this is the recommended 2027 standardized standalone dental plan. The committee reviewed several plan options with the potential plan changes having really minimal impact to the overall monthly premium. The HBBQ committee agreed to leave the plan as is and make no plan changes for 2027. So with that said, I believe we're going to hold off voting until on this plan option until all materials have been presented. So before I hand this off to Ren, are there any questions regarding this plan design?
What's the significance of the little circle there?
I'm sorry, that is the identifying the out-of-pocket maximum, which
is unchanged.
Yeah, which is unchanged.
Okay, thank you. Keep going.
Yep.
Thank you.
Thank you. And
good
I'll
morning,
hand this-
everyone.
Oh.
Okay. Yeah, good morning, everyone. Thank you for having me. I'm Ren Zhang, Consulting Actuary from Weekly Consulting Group. Today, I'll walk through the proposed 2027 individual market standard plan designs. And I want to thank everyone's hard work and support during this process. In this presentation, we'll cover 4 key areas: proposed regulatory changes, updates to the Federal Actuarial Value Calculator, 2027 AV calculator results, and proposed 2027 standard plan designs. Next slide, please. Before we review the plan details, I'd like to briefly outline the 4 key elements that inform the development of standard plan designs. First, the Notice of Benefit and Payment Parameters, or NBPP, is an annual regulation issued by the Centers for Medicare and Medicaid Services. It defines the standards and policies for plans offered through the ACA marketplace. Second, the Federal Actuarial Value Calculator, or AVC, is an Excel-based tool used to measure a plan's actuarial value. Actuarial value represents the share of total healthcare costs that a plan is expected to cover, with a higher AV indicating more generous benefits. Third is the IRS regulations define the allowable deductible and out-of-pocket limits for HSA qualified high deductible health plans. Finally, the issuers conduct their own testing to validate actuarial value and ensure compliance with mental health parity, which ensure the equity of mental health services. In practice, cost sharing and access to mental health services must be no more restrictive than those applied to comparable medical services. Next slide, please. And this slide summarizes the key regulatory changes for 2027. The Notice of Benefit and Payment Parameters defines many of the core plan design parameters each year, including the maximum out-of-pocket limits for all plans, as well as the cost-sharing reduction, also known as CSR plan variations. For 2027, the maximum out-of-pocket limit for a single coverage is increasing from $10,600 to $12,000, with corresponding increases for CSR variants, as shown in the table on the right. In addition, IRS guidance defines the allowable deductible and maximum out-of-pocket requirements for HSA qualified high deductible health plans. For 2026, the deductible has to be at least $1,700 to be qualified to be an HSA plan, and the maximum out-of-pocket limit is $8,500. The 2027 IRS limits have not yet been released. Next slide, please. This slide shows the changes to the federal actuarial value calculator. First, the data underlying the AV calculator was updated. The data is based on 2021 to 23 EDGE individual and small group data and trended to 2027. EDGE data is health insurance claims data that insurers submit to the government to calculate risk and payments under the ACA. The two tables in the middle list the medical and the pharmacy trends from 2021 to 2027. Second, the demographic weights are adjusted to reflect the 2027 anticipated population. Next slide, please. Now we move into plan design overview. First, we evaluated actuarial values of current standard plan designs to determine whether they remain within the required de minimis ranges under the 2027 AV calculator. For plans that fall outside of the allowable ranges, we tested multiple scenarios by adjusting key cost-sharing parameters and developed several potential design options. Issuers then performed their own validation, including actuarial value testing and mental health parity compliance testing. Based on this process, a final set of options was developed and presented to the Health Plan Benefit and Qualification Advisory Committee for recommendation. The two tables on this slide summarize the actuarial values for both the current and proposed standard plan using the 2026 and 2027 AV calculators. The first table shows the results by metal tier. The second table presents the results for silver cost-sharing reduction variants. In the first table, for example, gold plans are required to fall within the AV range of 78 to 82%. As shown in the table, the current plan designs meet this requirement under the 2026 calculator, with AV ranges from 78.7 to 81.4%. However, when evaluated under the 2027 calculator, the same designs exceed the allowable range, with AVs increasing to 85.3%. The proposed 2027 plan designs bring AVs back within compliance, ranging from 79.4 to 81.1%. Next slide, please. The federal AV calculator evaluates actuarial value based on the defined set of core service categories. This table highlights several additional service categories that are included in the standard plan design but are not considered in the AV calculation. Next slide, please. Before we review the plan designs, a few clarifications on the information presented in the following slides. The cost sharing reflects in-network services only. Deductible and the maximum out-of-pocket amounts are for individual coverage. Family limits are 2 times the individual amounts unless otherwise noted. Preventative services are covered at no cost to members across all plans. Mental health cost sharing is aligned with the primary care for all plans. Silver loading for defunded CSR plans are expected to continue. And all plans use embedded deductible structure, meaning each member has an individual deductible and maximum out-of-pocket limit. And coverage begins for that individual once their limit is met, even if the family maximum hasn't been reached. Next slide, please. Now let's turn into standard plan designs. In each table in the following slides, the first column lists the benefit category. The second column shows the 2026 plan design, and the remaining columns presents the proposed 2027 design options. We start with the standard gold plan. 3 options were presented to the Health Plan Benefit and Qualification Advisory Committee. The options were assessed with a focus on maintaining compliance while minimizing disruption to the overall benefit structure. Following their review and evaluation, option 2 was selected. Next slide, please. Now we move to standard silver plan. Similar to gold, 3 plan options were presented to the committee. After reviewing all the options, the committee approved option 4. Next slide, please. For silver cost sharing reduction variants, plan designs were evaluated across 3 income tiers at the 73, 87, and 94% AV levels. For a 73% CSR plan, the committee approved the option 2. Next slide, please. For 87% CSR plan, the committee approved option 1. Next slide. For 94% CSR plan, the committee approved option 1. And next slide. For the standard bronze plan, formerly as a bronze non-HSA plan, the committee approved option 2. And next slide. And from bronze high deductible health plan, also known as HDHP, formerly as bronze HSA, the committee approved option 1. And as Kelly mentioned, we also proposed a new standard bronze plan as bronze light. The committee approved option 1. Next slide. Lastly, we'd like to note that Connecticut mandates require coverage of diabetes drugs, supplies, and services. However, the HSA qualified bronze plans must also comply with federal IRS guidance on pre-deductible services. As a result, for bronze high deductible health plans, the state statute requires the plan to cover diabetes services pre-deductible only for those allowed under IRS guidance, for example, insulin and certain medications, and apply deductible to others. And some details listed in this slide. Okay, so this concludes the presentation of the proposed 2027 standard plan designs. And thank you very much.
Thank you. This is such a needle threading exercise every year. So my appreciation to Wakely, to the committee, to the staff who do this. It's a very complicated task, and you always have to sort of make trade-offs that make sense in the real world. And kudos to everyone for having done this hard work. Any comments or questions or corrections on these plans as they've been presented to us? If not, then I thank you very much for the very thorough analysis here. And again, my thanks for the hard work. Marcin, these are fairly specific votes, so I'm going to ask you to tee them up. I think there's 6 or 7 of them, and if you wouldn't mind, we'll just try to go through them as quickly as we can.
Yes, Mr. Chair. So Chair Charles Kleppel requests a motion to approve option 2 as the standard individual market gold plan for plan year 2027 as presented by Wakely Consulting on behalf of Exchange staff. Is there a motion?
So moved. This is Grant.
Mr. Chair, second.
Gifford.
Gifford, Dr. Gifford, thank you. Any discussion? Roll call vote. Charles Kleppel?
Yes.
Paul Philpott?
Yes.
Groundreader?
Yes.
DJ Gifford?
Yes.
Steven Hernandez? Matthew Brockman? Thomas McNeil?
Yes.
Dina Berlin?
Yes.
Andrea Barton Reeves?
Yes.
Kathleen Holt?
Yes.
And Claudio Gualtieri?
Yes.
Thank you. Motion passes. Mr. Chair, would you like me to continue with the standard silver plan?
Keep going. Yep, please.
Okay. Chair Charles Kleppel requests a motion to approve option 4 as the standard individual market silver plan for plan year 2027 as presented by Wakely Consulting on behalf of Exchange staff. Is there a motion?
So moved. This is Grant again.
Thank you. A second?
McNeil, second.
Thank you. Any discussion? Charles Kleppel?
Yes.
Paul Philpott?
Yes.
Groundreader?
Yes.
DJ Gifford?
Yes.
Steven Hernandez? Matthew Brockman? Thomas McNeil?
Yes.
Dina Berlin?
Yes.
Andrea Barton Reeves?
Yes.
Kathleen Holt?
Yes.
And Claudio Gualtieri?
Yes.
Mr. Chair, with your permission, I will continue with the standard silver plan CSR variants. Okay. Chair Charles Kleppel requests a motion to approve the standard silver 73% plan option 2, the standard silver 87% plan option 1, and the standard silver 94% plan option 1 as the standard CSR tier plans for plan year 2027 as presented by Wakely Consulting on behalf of Exchange staff. Is there a motion?
So moved. This is Grant.
Thank you. Second?
Paul, second.
Thank you. Any discussion on the motion before us? Roll call vote. Charles Kleppel?
Yes.
Paul Philpott?
Yes.
Groundreader?
Yes.
DJ Gifford?
Yes.
Steven Hernandez? Matthew Brockman? Thomas McNeil?
Yes.
Dina Berlin?
Yes.
Andrea Barton Reeves?
Yes.
Kathleen Holt?
Yes.
And Claudio Gualtieri?
Yes.
I will continue with the standard Browns plan. Chair Charles Kleppel requests a motion to approve option 2 as the standard Browns plan for plan year 2027 as presented by Wakely Consulting on behalf of Exchange staff. Do we have a motion for that?
So moved, Grant.
Thank you. Is there a second?
Second.
Thank you, Mr. McNeil. Any discussion on the motion? Charles Kleppel?
Yes.
Paul Philpott?
Yes.
Grant Ritter,
Yes.
DJ Gifford,
Yes.
Steve Hernandez, Matthew Brockman.
Yes.
Steve Hernandez, yes. Okay, thank you. Matthew Brockman, Thomas McNeil,
Yes.
Dina Berlin,
Yes.
Andrea Barton Reeves,
Yes.
thank you. Kathleen Holt,
Yes.
and Kaldu Galtieri.
Yes.
Thank you. We have 3 more votes. We're almost there. Standard Browns HDHP. Chair Charles Clipper requests a motion to approve option 1 as the standard HDHP Browns plan for Plan 2027 as presented by Wakely Consulting on behalf of Exchange staff. Is there a motion for that?
So moved, Grant.
Thank you. Second?
McNeil second. All
Thank
second.
you. Mr. McNeil, thank you. Any discussion? Charles Klippel,
Yes.
Paul Philpott,
Yes.
Grant Ritter,
Yes.
DJ Gifford,
Yes.
Steve Hernandez,
Yes, motion.
Matthew Brockman, Thomas McNeil,
Yes.
Dina Berlin,
Yes.
Andrea Barton Reeves,
Yes.
Kathleen Holt,
Yes.
and Claudio Galtieri.
Yes.
Thank you. 2 more to go. Standard Browns Light Plan. Chair Charles Klippel requests a motion to approve option 1 as the Standard Browns Light Plan as presented by Wakely Consulting on behalf of Exchange staff. Do we have a motion for that?
So moved, Grant.
Thank you. Second?
Second, Gifford.
Thank you, Dr. Gifford. Any discussion? Charles Klippel,
Yes.
Paul Philpott,
Yes.
Grant Ritter,
Yes.
DJ Gifford,
Yes.
Steve Hernandez,
Yes.
Matthew Brockman, Thomas McNeil,
Yes.
Dina Berlin,
Yes.
thank you, Andrea Barton Reeves,
Yes.
thank you, Kathleen Holt,
Yes.
and Claudio Galtieri.
Yes.
Thank you. And the last one, standard standalone dental plan. Chair Charles Klippel requests a motion to approve the current 2026 standard standalone dental plan as presented by Exchange staff as the standard standalone dental plan for 2027. Do we have a motion for that?
So moved, Grant.
Thank you. Second?
Second.
McNeil second.
Thank you, Mr. McNeil. Any discussion? Charles Klippel,
Yes.
Paul Philpott,
Yes.
Grant Ritter,
Yes.
DJ Gifford,
Yes.
Steve Hernandez,
Yes.
Matthew Brockman, Thomas McNeil,
Yes.
Dina Berlin,
Yes.
thank you, Andrea Barton Reeves,
Yes.
Kathleen Holt,
Yes.
and Claudio Galtieri.
Yes.
Thank you. Thank you. All motion passes. All the motions pass.
Thank you. And thank you, Marcin, for doing that complex little work. The James, I'm sorry. We have one more item. Susan.
I will go super quickly, and I really appreciate everyone's being here for this meeting, getting all this work accomplished. As I think was mentioned earlier, we are still waiting on the final notice of benefit and payment parameters from CMS for plan year 2027. This is how the agency does its rulemaking for the upcoming year. It was published on the late side as well in February, and it had a 30-day comment period. And it has a number of regulations in there related to changes, as we've been talking about today, from HR 1. There are also some changes in there for network adequacy requirements. There are some fairly large different changes proposed for bronze and catastrophic plans. And then there is also changes for the state exchange improper payment measurement program that is starting up. It was in a pilot that we participated in, and they were proposing to start in 2027. Access Health and others have requested they put that off to 2028 with all of the changes coming up. And then another item was seeking input on the pre-enrollment verification requirement guidance that will, for all of the new requirements going into place for plan year 2028. So as soon as that is finalized, we can write up a memo for the board to give you an update on what they decide to finalize on this requirement. Thank you.
Chairman, very quickly, just the couple of future agenda items. No one is 10 clicks. We'll keep the board up to date on that, obviously. And the other ones also, we have, we are currently going through a number of audits, state audit. And then pretty soon we're going to start our regular financial audits from our external auditors. So all of that will be presented to the board in the near future. Thank you.
Mr. Chair, I think you're muted.
Thank you, James. Any other comments or questions for the good of the order? If not, I want to thank you as always for your hard work in these efforts. It really is important, and I really appreciate all the input and thoughtfulness of this board. So thank you. With that, I would ask for a motion to adjourn the meeting.
Mr.
Move
Chair, this is
adjournment.
Claudio. Okay, go ahead.
After
okay.
you, Claudio.
Okay.
I don't want to make it appear that we're all excited to end this meeting. It was a very productive and great conversation.
So motion was made by Mr. Gualtieri, and I believe Dr. Gifford will second the motion. Is that correct?
I second the
Okay,
motion to adjourn.
Thank you. A roll call.
Question.
Charlie.
Yes, yes, thank you.
Thank you. Paul Philpott.
Yes.
Grant Ritter.
Yes.
Deidre Gifford.
Yes.
Steven Hernandez.
A reluctant yes.
Matthew Brackman. Thomas McNeil.
Yeah.
Dina Berlin.
Yes.
Thank you. Andrea Barton Reeves.
Yes.
Kathleen Holt.
Yes.
And Claudio Gualtieri.
Yes.
Thank you.
Look forward to
Have a
seeing
great
you all
day.
on June the 10th. Thank you so much, everyone.
Bye-bye all. Thank you very much, everyone.
Bye-bye.